Well, there's a couple of things to consider. One is that particularly in these times where there's so much scrutiny and criticism of the treatment of chronic pain, how that's done, then prescribers are under a lot of pressure to conduct a sufficient evaluation so that for whatever decision they make, whether it's to prescribe or not to prescribe, that they can justify that. And so there are guidelines that are put out by American Pain Association and AAPCC, by the pain associations. And these guidelines include certain things that should be evaluated and assessed particularly in order to put somebody on long-term opioid therapy. So what we did was we constructed a electronic assessment so that patients could do this. They could do it at home, they could do it in the office, and then it automatically generates a report for the prescriber that can go directly into the medical record and essentially provides the documentation that really ought to be in the medical record for a patient with chronic pain. We did a field trial, and in that field trial we found that in going back and looking at patients' medical records, that these elements, these chart elements, were much more likely to be included in the patient record when this kind of pain assessment is implemented, as opposed to treatment as usual with just the prescriber documenting in the sort of old-fashioned way. So one way to look at this is that it has this kind of electronic, systematic, and standardized assessment has utility on the individual patient level. Since those data are collected electronically, they can be digitized and they can be aggregated. So then it allows us to start looking at groups of patients. So we can look, for instance, at how patients differ across different providers, the level of risk that different providers see. Some prescribers see patients at higher risk than others, and then how those patients are treated by the prescribers. We can also monitor patients over time, and we can essentially do a comparison of outcomes. Ultimately, once we have enough data, we might be able to begin to do advanced analyses of the data and understand how different types of patients, so maybe back pain, fibromyalgia, migraines, how different types of patients respond to different kinds of treatments and get the best outcomes on an aggregate level, so that we can maybe understand better how different kinds of patients should be treated differently. All these people are different and they have different presentations. So this, maybe opioids work better for one group and not so good for another group. And we hope to be able to demonstrate that. And since it's not a research study, these are data that are collected in ongoing clinics. This is real-time, real-life data. So it's not part of a study where you have people who are, have volunteered for the research. And all of this is done in a way that's HIPAA compliant and is considered to protect the confidentiality of the patients and of the providers. The challenge that we're running into, we have it currently in about 21 different clinics across the country where it's being used right now, and that is continuing to grow. And what we are finding is that we need to work with the clinics to fit this kind of assessment into their clinical flow. So we have a system that will automatically send a link to patients prior to their assessment, so they can do the assessment. It's already done when they come into the office. If they have not done it, then the office can hand them a tablet where they can sit in the room and privately complete this. We've been working on the length of the assessment so that it's short enough, collects enough data, but it does it in a short enough period of time so that it fits into the clinic flow. And so fitting into the clinic flow is one of the major challenges. And the other challenge is what we want to do is have those data imported effortlessly and automatically into the electronic medical record. We can do that in the way that many tests are done, which is essentially attaching like a PDF to the medical record. So the information is there, but the more effective and the sort of fancier way of doing that is having the data elements automatically imported into the medical record. So we've been working with the software engineers that work with Inflection, the company that I work with, and the engineers from the medical record companies to facilitate this kind of integration. So this is happening across the country. It's an issue that is, because there's, different medical records have their own sort of proprietary platforms. And I think that we're involved, as are other, I guess you'd call them vendors, that are working with the companies to integrate seamlessly with the electronic medical record. We are looking at various ways of making collecting this sort of data more easily done by the patient, for the patient. So to be able to do to be able to maybe quickly answer a few questions on their mobile device, rather than sitting down at an old style computer. I mean, that used to be modern, and now it seems old. So while we do have mobile and sort of iPad applicability, it's, I think, more work on how that can be done to make to make this easier and in more real time. My co-presenter, Dr. Jamison, is going to talk about collecting data on how, at the moment, using the cell phone throughout the day, because pain intensity and the pain ratings change throughout the day. Sometimes it's worse in the morning, sometimes worse in the evening, and so I think the future of this kind of assessment will be in that direction, as well as possibly wearables like the Fitbit, and use of that kind of, kind of biotechnology to get real-time patient data. So those are some initial thoughts.